Yes, sir, we are live now.
Good evening, everyone. Welcome to the Meet the Master series. As you know, myself is Dr. Swarna Deepak. I'm the Secretary of ISCCM Hyderabad, and it is our pleasure and privilege to invite you to our every one of the most popular programs from Hyderabad ISCCM, Meet the Masters, where we will be regularly interacting one of the pioneers in the specialized field. Today we have none other than Supradip sir. Dr. Supradip sir is one of the senior most intensivist in the country, as well as well known all over the world as well, especially for his work in the fluids. So, sir is an intensive care physician and both an internist, presently working as a director and head of the department, critical care medicine, from Fortis Escort Hospital, Faridabad. Uh, I'm fortunate to have listened to his previous lectures in the past, and I am also eager to listen to him. So he is an armed force veteran. Thank you for your service, sir, from the Indian Navy. He's an accredited teacher and senior examiner, both for the national board exams as well as ISCCM exams. So today we'll be charting through, and sir will be taking us through the interesting topic of fluids. So we know we day in and day out will be dealing, all our intensivists will be dealing with the fluids. So sir will be going through the logics and intricacies of it. So I don't want to spend much time, and I want to eagerly listen to sir. Sir, over to you, sir.
Thank you, Dr. Swarna Deepak, and thanks ISCCM Hyderabad chapter for giving me the opportunity to interact you all on this topic, which is very close to my heart. And I believe after the end of this lecture, most of you will be very eager to learn more and more and more from about fluid and how to manage the fluid in a appropriate manner. So the topic is fluid stewardship. So all of us are aware about the antibiotic stewardship. So I believe fluid is something like antibiotics, like all, and in fact, all other drugs. It's a drug. First of all, let us accept the fact. Like any other drugs, this drug has indication, it has contraindications, it has a plethora of different compounds available within the same basket. Each compound has its own role, and we need to choose a particular fluid for a particular indication in that particular patient. So, and apart from that, we also need to monitor these, just like antibiotics and other drugs. We need to look for the complications of the fluids, just like any other drugs, whether it is a metabolic acidosis, fluid overload, or hypokalemia, hyperkalemia. All these things needs to be considered. Similarly, like any other drugs, fluid also requires dosing. You just cannot write 3 bags of fluid. You need to write this much amount of fluid over this many hours, then and look for these things. And like any other drugs, it needs to be discontinued sometimes. So based on this, we feel, and since intravenous fluid is just like oxygen and sometimes a very overly abused drug, because you go to any hospital, the first thing you will find is patient is receiving some amount of oxygen, whether they require it or not, and they are invariably on some intravenous fluid. So based on this, we feel, and I feel particularly, that we need something called fluid stewardship. And I'm thankful to ISCCM for Hyderabad branch that to giving me this opportunity to talk about what I feel and what I think about the subject. So like any other drugs, we need for fluids also, we need right indication, right drug, right appropriate dose, the right dose, and for the right duration. Hopefully at the end of this session, you will be able to agree with me that how do we go about it. So just to make it a little more, okay. All right. So, whenever we give intravenous fluid or we want to prescribe intravenous fluid, you need to ask ourselves, why do you need these fluids? Shall we give fluid for resuscitation? That means with an idea that intravenous fluids will increase the venous return, and in and also the cardiac output? Or is it for maintenance just because our patient is not on any drugs, any oral fluid or any parenteral nutrition or enteral fluid? Or is it for to replace fluid which has already been lost? Or is it because of certain hidden ones? If we go by the study, and if you go through the data which is available at present, we know that in resuscitation fluids, but fluids we use for ICU patient only for the purpose of resuscitation, that is only 6.5% of the total volume administered, a meager 6.5%. And interestingly, most of the research which you will be seeing now is focusing only on this 6.5% of the volume administered as resuscitation fluid. In contrast, 1/4 of the volume we give in ICU patients are because of either maintenance fluid or as a replacement fluid. It is 1/4, 25%. Whereas there are some other fluids called fluid creep for that matter. Fluid creep is something, the fluids which we use for the purpose of dilution or for flushing. All these things occupied a whopping 33%, 1/3 of the volume administered. Another 33% is occupied by the enteral fluid. So we need to ask ourselves, why do you want to give fluid? It is not just to give fluid. We need to understand again and again and again and again, just like any other drug. Why do you give it? Why do you want to give it? Is it for resuscitation? Is it for maintenance? Is it for replacement? Or just for the dilution purpose? So after we come to this, after we know why we are giving a fluid, let's see this case. This 56-year-old lady, a diabetic and hypertensive with history of old CVA with residual left hemiparesis, was admitted to us with altered sensorium following a brief period of fever for 4 to 5 days. We found that her GCS was around 9 with a motor response maximum of 5. Her extremities were cold and she has grade 4 mottling. I hope you can appreciate from this photograph that grade 4 mottling, which is extending beyond half of the thigh. And she had a heart rate of 124 and she was hypotensive with a BP of 84 by 50 millimeter of mercury. Her ABG showed a base axis of -16, that means metabolic acidosis with some respiratory component. Plus the lactate was 8.4. We obviously did a blood sugar was around 88, and her other clinical examination findings were not very contributory. Her neck was supple, so there was no evidence of meningism. So with this, our patient is in shock. Considering the fever and other things, probably we are dealing with a patient of septic shock. BP of 84 by 50, grade 4 mottling with a high lactate and high base axis. We are dealing with a shock. Now the question is, ICU physician, it can be you and me or anyone, we decide to give some fluid, intravenous fluids. So we will decide to give a fluid bolus of 500 ml over next 15 minutes. So what should be the most appropriate fluid? Here the fluid choice is a resuscitation fluid. Is it a 0.9% saline, Ringer's lactate, 6% hydroxyethyl starch, 3.5% gelatin, that is Himaxil, or would you like to go for a 5% albumin? I would like you to give your answer in the chat box provided. Don't worry. Nobody is wrong. Nobody is right. Just give your answer, whatever you feel. Over to you, Dr. Swarna Deepak. So you have 30 seconds.
I was just seeing the answers. So there were a couple of interesting answers to this answer. The most, I think, one of the most interesting one was it depends. So it depends on the fluid responsiveness is one answer. Saline is one thing I think many people are opting. So second is RL. I think other fluids they haven't opted.
Okay, that makes sense. That makes sense. So if you see, the first two are crystalloids and last three are the colloids. So let's look what are the options we have as resuscitation fluids. So resuscitation fluids can be classified broadly into two groups, either the crystalloids, these are the clear solutions of only electrolytes, or the colloids. Colloids are large compounds which are suspended in some crystalloid. So these are the colloids. Out of the colloids, we have natural colloids like albumin, or we have synthetic colloids like hydroxyethyl starch or gelatins or dextrans. Again, hydroxyethyl starch can be classified based on the molecular weight, based on the substitution ratio, based on the many other factors. Gelatins can be classified into either succinylated gelatin or what we get, the hemaxin. Or we have dextrans. Dextrans can be again dextran 40, dextran 60, something like that. We have albumin, again available in two different forms, either iso or hypo-oncotic albumin like 4.5% or 5% albumin, or we have hyper-oncotic albumin like 20% and 25% albumin. Amongst the crystalloid, we have either isotonic crystalloids for resuscitation. Please do not give hypotonic fluid for resuscitation. Or we have hypertonic saline like 3% saline. Biggest debate is, what about the isotonic compounds? Amongst the isotonic compounds, we have either 0.9% saline, or we have certain things called balanced salt solution. We'll come to this debate in later part, which one is better. Amongst the balanced salt, it is not a single thing. There are at least 4 different compounds which are available, out of which Ringer's acetate is not there. In India, we have Ringer's lactate, which is the most commonly used. We have plasmalite or kebilite, or we have something like styrofundine, which is there. So these are the options we have. Now, what do we give? Now let's clear our doubt regarding whether to give crystalloids or whether to give colloids. Before that, let's understand that colloids are much costlier substance. So I would like to give colloid only if it has got an advantage over crystalloid in terms of some substantial mortality reduction or reduction in the organ dysfunction score or something like that. Or otherwise, I would not like to give colloids at all to any patients. So let's see whether colloids can reduce the mortality or not. So this was a study called Crystal study, which was published back in 2013, where around 3,000 patients were randomized to receive either colloids exclusively. This colloid can be anything, hydroxyethyl starch, gelatin, or albumin, versus resuscitation exclusively with crystalloids. And if you can see, the 28-day mortality or any other patient-specific outcomes were not different between two groups. So I would like to ask you, why shall we give a compound which doesn't have any patient-centric advantage and which is costly? So coming to that, but what about albumin? There was a debate going on for quite some time from late 1990s that albumin can be actually harmful to our patients. And this was actually ignited by a big meta-analysis by this Cochrane review group, which showed that albumin can increase the mortality by more than 40%. That's a substantial number. So there was a need to find out whether actually albumin is harmful or not. So this Australia-New Zealand group, they did a study which is remarkable for its size. In those days, probably this was the largest study in critical care. 7,000 ICU patients were randomized to either resuscitation with 4% albumin. Remember, 4% albumin is a hypo-oncotic albumin, hypo-oncotic fluid, versus 0.9% saline for resuscitation. Interestingly, they could find that contrary to the belief of the Cochrane review group, 28-day mortality was not increased in general in 4% albumin group when they were compared with 0.9% saline. So albumin is overall safe. This albumin is hypo-oncotic albumin. For resuscitation, albumin is safe. But does it automatically mean that we should give albumin? I'm not sure, because why shall we give a substance which does not improve the mortality or other patient specific benefit? They also could find that there was no difference in the organ failure between the two groups, but albumin was associated with an increased mortality in patients with trauma, especially in patients with traumatic brain injury. So this same study was published in 2004. Subsequently, the same group published another study just focusing on patients with traumatic brain injury called SAFE TBI in NEJM somewhere in 2006. And there they could substantiate that giving albumin for resuscitation compared to 0.9% saline in patients with traumatic brain injury is harmful. They both increase mortality and they also worsen the Glasgow outcome score. So what does it mean? So colloid overall does not have any advantage. Albumin is safe, but it can increase mortality in patients with traumatic brain injury. This is hypo-oncotic albumin. But there is something called hyper-oncotic albumin. One more benefit of colloid, which is it can actually reduce the cumulative fluid balance. This was another reason why colloid was propagated. But we could not see a similar benefit in studies on hydroxyethyl starch or albumin. But when we gave albumin in 20% to 25%, I mean hyper-oncotic albumin group, maybe there is a better volume expanding effect compared to a normal 4 to 5% albumin. And this was seen by a small study called SWIPE study from two Australian ICU and two ICUs from UK. In this study, 321 patients were randomized to receive 20% albumin versus 4 to 5% albumin for resuscitation. Any patients who were requiring fluid bolus. And they could find that giving 20% albumin can decrease the total study fluid intake. An intravascular volume effect of 20% albumin is more than 2 times that of 4 to 5% albumin. But remember, this was a small study. Remember, this study was mostly done on elective surgery. So we need to have more data to actually say that we should use 20% albumin routinely in our patients. But yes, there is a scope for 20% albumin or 25% albumin as a volume sparing drug. So, ladies and gentlemen, as of now, we are not seeing much benefit from colloid as such. So, what about crystalloids? And we cannot forget this hydroxyethyl starch story. So there are several studies published recently which has shown consistently, including bicep, 6S, and chest, consistently they have shown hydroxyethyl starch not only produces any difference in mortality compared to crystalloids, but they invariably causes increased incidence of acute kidney injury and need for renal replacement therapy. So this is across all big studies, whether it is bicep, whether it is 6S, or whether it is chest. So hydroxyethyl starch is out. So is dextran and gelatin. So to conclude, colloid, no benefit, no additional benefit. In fact, some colloids can be harmful, like biceps, like hydroxyethyl starch or gelatin or dextran. They increase the acute kidney injury incidences. Albumin may be safe, but they are harmful in patients with traumatic brain injury. We need more data for 20% to 25% albumin. So we are left with only crystalloids. Out of the crystalloids, we have, as we have seen, that we have 0.9% saline, which is a solution of sodium and chloride in water, which has a concentration of sodium of 154 milliequivalent per liter and a chloride concentration of 154 milliequivalent per liter, resulting in a strong ion difference of around 0. So, but the 0.9% saline has been shown to increase the incidence of acidosis with a potential for renal injury and coagulopathy. And this was seen by multiple before and after study, mostly performed by the Australian ICU, and with the first author of Dr. Magdi Yunus. So 0.9% saline, it can produce hyperchloremic metabolic acidosis, but we do not know what is its impact on ICU patients' outcome. It can potentially increase the renal injury because of its increased chloride content, because of tubulo-glomerular feedback. And this has been shown in observational study. It can also potentially increase the coagulopathy when used in large volume. In a study from United States of America, it's an observational retrospective study of around 5,000 patients. They could see that using 0.9% saline can increase the mortality too. And this increased mortality associated with 0.9% saline was dose dependent, meaning thereby you give more saline, more death. But can it be substantiated in a randomized controlled trial? So there are 6 large randomized controlled trials which has compared 0.9% saline with balanced salt solution. Now let us come to balanced salt solution. What is balanced salt solution? Balanced salt solutions are again isotonic crystalloids with a composition closely resembling the serum and which also have buffering substances. For example, Ringer's lactate. It has a buffering substance of lactate. For example, plasmalite or kabilite, it has got a buffering substance of acetate and gluconate, whereas tirofundin is a standalone balanced solution which has got a buffering substance of maleate and acetate. So these compounds, they are not same. They have a differences in their composition in terms of electrolyte composition, in terms of their strong ion difference, in terms of their buffering substances. So they are slightly different with each other. So we need to understand that also. So what about the difference? What about the RCTs? What did we see in these 6 RCTs, starting with split and the latest one, the PLUS study? When we see this RCT, we can just say there are 2 different types of RCT. In split, basics and the PLUS. Split was published from Australia, basics was published from Brazil, and PLUS was published again from Australia. These 3 studies, the randomization between 0.9% saline and the balanced salt solution, mostly plasmalite or kabilite, was done after the patient got admitted to the intensive care unit. So many of these patients have actually received 0.9% saline before admission to the intensive care unit. So in those studies, they did not find any difference in the outcome. Whereas the studies in which balanced fluid, the randomization was done before the patient got admitted to the intensive care unit. These are SMART study, SALT study, and SALT-ED study from the Vanderbilt University of United States of America. In this study, they could find a better outcome with balanced salt solution. And what are those better outcomes? In SMART study, they could find that a composite outcome of MAKE 30, which means that major adverse kidney events were significantly lower when the patients were randomized to balanced salt solution. And these balanced salt solutions were mostly Ringer's lactate. Whereas in SALT-ED study, the hospital length of stay was significantly lower when patients were randomized to Ringer's lactate, mostly Ringer's lactate balanced salt solution compared to 0.9% saline. So, ladies and gentlemen, again, there is a difference in this randomized control trial. Whether the randomization was done before ICU admission or it was done after ICU admission. Before ICU admission, if the randomization is done, there is a significant difference favoring balanced solution. Whereas when the randomization was done after the ICU admission, there was no difference. So can we go further? So recently there was a sub-analysis of data from basic study, and there Fernando Jampieri and his team could find that there is an improved 90-day mortality in balanced fluid group when balanced solution was exclusively used before pre-enrollment. So ladies and gentlemen, if you use balanced salt solution from the initial part of the resuscitation, even before admission to the intensive care unit, there is a strong association towards improved mortality compared to 0.9% saline. Similarly, another study just published last month in Intensive Care Medicine in January issue, they could find that balanced salt solution can decrease mortality when patients receive higher volume of fluid. So maybe volume of fluid is also an important factor. So higher the volume of fluid you give, there is a worse outcome with saline compared to balanced salt solution. Just to summarize the whole thing, we have a trend towards using balanced salt solution. Favorable outcome can be seen with balanced salt solution compared to 0.9% saline in overall ICU patients. However, we need to consider differences in different balanced salt solution, and we need to consider other factors which probably we'll be discussing at the end of the session. So overall, balance is a preferred one. What about hyperoncotic albumin? Again, this big study, HYPER-S2S study from France, they could not find any difference of any benefit of 3% saline resuscitation compared to 0.9% saline. So this is practically out. So my take home at this point is isotonic crystalloids, either 0.9% saline or balanced salt solution should be our first line drug for resuscitation. Balanced crystalloids definitely has an edge over 0.9% saline. However, 0.9% saline should be used in selected patients. For example, patients with traumatic brain injury. Most of the balanced salt solutions, they are hypoosmotic, except tirofundin. So if you give hypoosmotic fluid for traumatic brain injury, there is a higher risk of increased intracranial pressure. So saline is preferred with a effective osmolality of 185. 0.9% saline is preferred also in patients with hypovolemic hyponatremia. 0.9% saline is preferred in patients with metabolic alkalosis with hypovolemia. And when you do not have any facility, for example, as a naval officer, I was posted in Andaman and Nicobar Island, where you didn't have much thing to choose from. So whatever is available, it should give it. So what about colloids? No added advantage, high cost. We have seen that synthetic colloids like hydroxyethyl starch or dextran or gelatin, they are associated with worse renal outcome, coagulopathy, and possibly mortality. So should not be used. Hypooncotic albumin, it is safe, but not in patients with traumatic brain injury, and for that matter, any patients with a high risk of raised intracranial pressure. Hyperoncotic albumin may be used in selected patients, but we need main major data. Hyperoncotic saline, hypertonic saline, no added advantage. Okay, let's come to the next case. I hope you are with me, my friends. So this was a 48-year-old male who was admitted to us with blunt trauma abdomen with mesenteric tear and bowel injury. He required massive transfusion. He underwent dissection anastomosis and was shifted to the intensive care unit. He was tachycardic, but his blood pressure was maintained with very low dose of norepinephrine. He was on mechanical ventilation with a SpO2 of 96% on FiO2 of 40%. And his CRT was normal. I used a lot of capillary fill time for less than 3 seconds. His lactates were decent with, remember, he underwent a dissection anastomosis. The lactate was marginally elevated with 1.9 millimole per liter, and base axis was -2. A plan was made that he will be kept neurally for next 48 hours. The question is, my friends, what should be the most appropriate choice of maintenance fluid for this patient? So this patient requires maintenance fluid. He doesn't require any resuscitation. He's not in shock. His shock could be well managed with a low dose of norepinephrine. His lactates are decent. His CRT is less than 3 seconds. Doesn't look to be in shock. So he'll require no further resuscitation fluid. He'll require maintenance fluid because he'll be kept nil by mouth, and there is no need of starting parenteral nutrition at this juncture in this patient. So we need to give some intravenous fluid for maintenance. And when you give intravenous fluid for maintenance, what are the choices we have? So here, these are the options. First of all, shall we give 0.9% dextrose normal saline plus potassium supplement? Or shall we give half dextrose normal saline with potassium supplement? Or shall we give 5% dextrose alternated with Ringer's lactate? Or shall we give 0.9% saline alternated with 5% dextrose? Or shall we give 0.9% DNS alternated with Ringer's lactate? You can mark your answer in the chat box. Dr. Swarna Deepak, your turn.
Yes, sir. It'll take 30 seconds, sir. I think they're quite confused with your choices you've given, sir. So one is 5% dextrose alternate with RL is one of them commenting. Second is Dr. Trishita Saha, she messaged that 0.9% DNS alternate with Ringer lactate. Some of them, I think, I don't know, they were quite confused. In fact, myself was.
So if you see, we have
third, fourth, and fifth, sir.
Okay. So if you see, we have very little data on maintenance fluid. There are very few randomized control trial in adult critical care medicine on what should be our best maintenance fluid, and in which patient which one to be used. But we need to follow certain principles. The principle one is we need to maintain, the whole idea is to maintain adequate hydration. So you need to give adequate volume of fluid, and that volume is usually followed by this Halliday-Segar formula, with first 10 kg giving some 1 liter, for second 10 kg give some 500 ml, subsequent kg you should give some 20 ml per kg. So this is to maintain hydration. Second thing we need to understand is we need to give adequate sodium to our patients, and that sodium requirement is 1 to 2 milliequivalent per kg body weight. Similarly, we have to give some potassium supplement if it is necessary. You can give up to 1 to 1.5 milliequivalent per kg of potassium if it is required, but not all patients doesn't require it. And finally, we need to give some dextrose containing fluid to reduce our production of our gluconeogenesis. So this mandatory glucose requirement is between 50 to 100 grams per day. So keeping in mind this fluid requirement, sodium requirement, potassium requirement, you have to use your calculation, and you have to use your drug. So there is, I'm not saying that this one is the best and that one is the best. Another thing we need to understand is how much sodium should be there in our fluid. So if you give too much sodium, for example, you give 0.9% DNS, that contains a large amount of sodium. Remember, in post-operative patients, we have a release of antidiuretic hormone because of both stress, one, surgical stress, two, because of the pain. So pain and surgical stress both can release ADH. So ADH can actually cause edema. They can retain the fluid. And if you give too much of sodium containing fluid, it will retain the fluid much more. And as we will be seeing later, that retention of fluid and fluid overload is a very important detrimental factor in our prognosis of our critically ill patients. So this is one side. Other side, especially in pediatric literature, they are afraid of hyponatremia and hyponatremia-induced seizure. If you give too little sodium, there is a higher risk of hyponatremia. Again, for the same reason, you are giving low sodium, ADH is high, so you are actually producing more hyponatremia and hyponatremia-induced damage, which is more pronounced in patients with pediatric age group. So to look for what should be the appropriate sodium content of our maintenance fluid, especially in post-operative patients. This study called TOPMA study was published in Belgium, where a very small number of patients, 70 patients who underwent some thoracic surgery, they were randomized to receive an isotonic maintenance fluid of around 0.9% DNS versus a intervention fluid of slightly hypotonic. It's a little bit of confusion. Intervention was hypotonic maintenance fluid, which is around 5% dextrose containing fluid with 54 milliequivalent of sodium. This particular fluid is not available in India. It is a commercial fluid from Baxter, available only in Belgium and France, not available in India. But we can, our similar composition is almost similar composition is half DNS, which contains around 70 milliequivalent per liter of sodium. This glucon also contains 54 milliequivalents of sodium. So they actually wanted to see whether isotonic fluid like 0.9% DNS versus slightly hypotonic fluid, which has a resemblance with 0.945% DNS, which one is better in terms of positive balance? So we know the positive balance is not good. So at 72 hours, they could find the patients who received a maintenance fluid with 0.9% DNS has higher positive cumulative fluid balance. And not only that, they also had higher hyperchloremia, and they also had more fluid overload. So if we go through the data, so whatever IV fluid we choose for our patients with post-operative patients in adult critical care, the sodium content should not be as high as 154 milliequivalent per liter. It can be something like 77 or 70 or 70 milliequivalent per liter. Moreover, this slightly hypotonic fluid, not 0.18% hypotonic fluid, slightly hypotonic fluid that also do not produce significant hyponatremia. So balancing the fact, if you go through the question, I think I will be going for choice number 2. So if I give 0.9% DNS plus potassium supplement, there is a higher risk of positive cumulative fluid balance. If we give 5% DNS alternated with Ringer's lactate, probably it will not supply, it will not take care of our sodium requirement, and also they will not take care of our mandatory dextrose requirement. So it is true for 0.9% saline alternated with 5% dextrose. So it is true for 0.9% DNS alternated with Ringer lactate. So we are left with 0.4% DNS plus potassium supplement. You may differ with me, and we'll be discussing further at the end of the session. Is it okay? So let's move on. So third scenario. So we had a 58-year-old male, hypertension and COAD, who presented to us with infective exacerbation of COAD, and where you can see the right side when there is a pneumonia. This patient was of average build, but he was febrile. Here he was hypotensive with a BP of 84/46 millimeter of mercury. His CRT was elevated with 6 seconds, and his ABC showed a mixed acidosis with a lactate of 4.8 millimole per liter and base excess of -16. So remember these keywords: CRT of 6 seconds, lactate of 4.8 millimole per liter, and a blood pressure of 84/46 millimeter of mercury. The question is, what should be the most appropriate resuscitation measure? I'm not talking about resuscitation fluid, resuscitation measure for this patient. Shall we give 2000 ml of Ringer lactate over next 3 hours? Shall we give 250 ml of Ringer lactate and look for the response? Shall we give fluid boluses only at this juncture? Shall we look for the fluid responsiveness and give fluid boluses only after that, only if it is positive? Shall we start norepinephrine infusion immediately? Or shall we go for a combination of 250 ml Ringer lactate plus norepinephrine infusion in this patient? Your time starts now. So this is the case scenario.
Sir, questions, can you show us?
Yeah.
Mm, they're answering 5 more, sir. They'll give 250 ml of oral and look for the response and
Yeah,
start nephrin simultaneously. That is the
that's great.
calm.
That's great. So let's move on, look for the evidence. So before we answer, so we need to understand that there are different stages of fluid resuscitation, as has been discussed in earlier. And the first stage is something called salvage stage. Here, our patient is in a desperate situation, like our situation. Our guy is in septic shock because of pneumonia, and he has a blood pressure of 84/46 with a high lactate and very high CRT. So this is a very desperate situation. Here, we give fluid, maintain a positive fluid balance, and we give fluid based on only the basic monitoring devices. We don't go for any extraordinary devices, or we don't check for fluid responsiveness or other things. We just give boluses because this is a salvage phase or rescue phase. Once the patient has received some amount of fluid, he is not in an imminent danger of death, then we go for something called optimization phase, where we try to optimize the perfusion. So we check for the fluid responsiveness and also see something like fluid tolerance or not, whether our patient will be intolerant to fluid. Based on this, we decide whether to give fluid or not. And here also, even in this stage, the positive fluid balance is maintained. Now, after first few hours, it is the salvage phase. Next couple of maybe 24 hours to 36 hours, it is the optimization phase. Once our patient is resuscitated, then you try to maintain something called stabilization phase, where we either give maintenance fluid or we start enteral feeding or, if required, parenteral feeding. And we try to maintain an euvolemia and always continue to look for any evidence of fluid overload. In the fourth phase, which comes around 4 days or 5 days when patient is recovering for his illness, in or her illness. And in this phase, we normally, a majority of the patient, they start diuresing themselves. They start pouring out urine. But if they cannot, and if there is evidence of fluid overload, here in this phase, we try to actively remove fluid. And this stage is known as de-escalation or evacuation phase. So you know this famous ROSE concept, or SOSD concept. SOSD stands for salvage, optimization, stabilization, and de-escalation, whereas ROSE stands for rescue, optimization, stabilization, and evacuation. So this is the basic concept. So our patient, he is right now in salvage or rescue phase. So we have to give fluid boluses. So there is no need of looking for fluid responsiveness at this juncture. Now, how much fluid boluses? Now, here comes the surviving sepsis campaign. Surviving sepsis campaign suggests that you have to give 30 ml per kg body weight, which comes around 2 liters over 3 hours. But unfortunately, this evidence is not based on solid. This recommendation is not based on solid evidence. Clinical evidence for it is absolutely limited. There is no clinical evidence at all. So I think, and many of my colleagues from across the world, they feel that this recommendation should be quashed, and we should go ahead with the original description of the fluid, where Dr. Thomas Latta said, "Having no precedents to guide me, I injected ounce after ounce of fluid, closely observing the patient." So give a little bit of bolus of fluid and see the response. So how much little bit? That is found in this beautiful study by Holman Aya and his colleagues, where he could find this minimal, he could define the minimum volume as 4 ml per kg. For this gentleman, 70 kg, it should be around 250 ml. So give 250 ml of fluid and then decide whether to give further fluid or not. Further fluid depends on the which stage of resuscitation the patient is, whether the patient is optimization phase or still remains in the salvage phase. It also depends on the patient's phenotype. For example, there are some patients like this patient who is in pneumonia. Typically, he is not hypovolemic or she is not hypovolemic. But what about patients who has presented with a GI disturbance, a GI sepsis, where the patient is usually hypovolemic also because of a lot of vomiting and loose stool? In that stage, the volume of fluid required will be significantly higher compared to a patient of pneumonia or meningitis. You also look for fluid responsiveness. We also look for fluid tolerant. Okay. So this is the dosing. So 30 ml per kg body weight, giving 2 liters of fluid probably is not a great idea. So giving around 4 ml per kg body weight and look for the response is probably a good idea. But what about the vasopressor? Remember, septic shock is a primarily vasodilatory state. And in many patients, giving norepinephrine can actually make the magic, can be a magic potion, or a combination of fluid and vasopressor can be a magic potion. So what can we do? Why it can help? It can help. Early norepinephrine can reverse potentially life-threatening hypotension. Remember, our patient had a diastolic blood pressure of 46 millimeter of mercury. Always remember, diastolic blood pressure is the one which maintains the perfusion of the heart itself. And maintaining a higher diastolic blood pressure is important to maintain the perfusion of the heart. Secondly, reduction, it also reduces the duration of hypotension. A beautiful study by a group of researchers from South Korea, they could find that the number of hours a patient remains hypotensive is directly proportional to the increase in death. So if our patient remains hypotensive for a long period of time, there is an increased incidence of death. So by giving early norepinephrine, it can reduce the duration of hypotension and thus it can decrease the mortality. Thirdly, norepinephrine in particular can increase a cardiac output. How? It can increase cardiac output because it's a vasoconstrictor. It can increase the stress volume. It can increase the mean systemic filling pressure. It can increase the venous return, and it can increase indirectly the cardiac output. Also, as I have said earlier, early norepinephrine can increase the diastolic blood pressure and increase the coronary perfusion. Fourthly, it can potentially reduce the cumulative fluid balance, because as soon as we can increase the mean systemic filling pressure, there is no need of giving further fluid to increase the mean systemic filling pressure. And finally, as we have shown from this study from Venice study from Thailand, which can show that early initiation of norepinephrine can also reverse the shock earlier. So because of these 5 reasons, it is important to make a magic potion of fluid and vasopressor. Now, when shall we start the vasopressor early? Number 1, if the diastolic blood pressure is very low, especially if it is less than 50, we must start norepinephrine as quickly as possible. In patients with extreme vasodilatation, when the pulse pressure is very, very wide, maybe more than 40 millimeter of mercury or 50 millimeter of mercury, we should start early vasodilatation, early vasopressors. Or if you have given 1 to 2 liters of fluid, the usual dictum is wait for patient to become fluid unresponsive, then start vasopressin. The vasopressor, that is probably not correct. Start vasopressor as soon as you have given 1 to 2 liters of fluid to these patients. So in our patient, let's go back to our patient. Our patient had a diastolic blood pressure of 46 millimeter of mercury. So those who have marked number 5, I think I'll go with them. So this patient requires fluid as well as vasopressor as early as possible. There is no need of looking for fluid responsiveness because he is in salvage stage, and there is how much fluid? It is 4 ml per kg body weight, and I'll wait for the patient response for this. Are you with me? Yes. Let's go to the case scenario 4. So here we had a 46-year-old diabetic male, female, who presented to us with pyelonephritis left-sided, as we can see from this, both from the echo, from the ultrasound, and from the CT scan. On examination, she was on drowsy but arousable. She had a diastolic blood pressure, 94 by 52 blood pressure with a MAP of 66. His capillary refill time was elevated, 6 seconds, more than 6 seconds, and lactate was 6 millimole per liter. Remember, this patient was still on room air with SpO2 of 96%. So she was started on norepinephrine infusion along with some fluid. She has already received 1.5 liters of fluid both in the emergency department and in the intensive care unit. Her lines are in place. There is a femoral arterial line and there is a right subclavian venous line in place. So we had a patient with diabetes mellitus, left-sided pyelonephritis, septic shock, who has received 1.5 liters of ringal lactate and is on low dose of norepinephrine, still continues to be in shock. What do we do next? What is the next best step to restore the tissue perfusion in this patient? Shall we give further bolus of 500 ml of ringal lactate? Shall we increase the vasopressor dose? Shall we perform a PLR to look for fluid responsiveness before further fluid bolus? Shall we measure CVP and give further fluid if CVP is less than 8? Or shall we look for PPV to decide further fluid infusion? Your time starts now.
So the commonest answer they're answering is 3, sir. Perform PLR for fluid responsiveness.
Okay.
And the second
So
one
everybody seems in favor of going for a fluid response, some sort of fluid responsiveness test before giving
correct.
further fluid. So these patients look like in the optimization phase. She is in optimization phase. Initial fluid has been given, initial norepinephrine is given, blood pressure is now decent, 94/52, but she still continues to be in tissue perfusion. So what shall we do? We should look for, to give further fluid, we need to look for fluid responsiveness. As we have seen from the data, that giving fluid, which with an ultimate goal of increasing cardiac output, may not be we don't achieve the same thing in 50% of the patient, meaning thereby in 50% of the patients we give fluid, cardiac output may not increase at all, but they continue to produce fluid overload. Second thing we have noticed from the great study by Andromeda Shock, which have shown that responsiveness of fluid boluses that decreases with time. So we need to look for some sort of fluid responsiveness. And as we know, which choice of appropriate test depends on several factors, whether it is the resource availability, spontaneous breathing effort of the patient, what is the cardiac rhythm, what is the respiratory rate, tidal volume, lung compliance, many things. So in our patient, obviously the patient is in spontaneous breathing. So PPV probably has got no meaning. CVP is not a great thing for fluid responsiveness prediction. So PLR probably an option. However, it will depend upon the resource availability, whether we have a real-time cardiac output monitor available for performing the PLR or not. If we do not have any test, or we do not have the resource ability, or the test of fluid responsiveness cannot be performed, or their validity is questionable, we also can perform something called fluid challenge. We don't have time to go into the details of fluid challenge, but yes, fluid challenge, a validated fluid challenge using the mnemonic TROL, type of fluid, rate of fluid, observation, and limit. The TROL, we can go for a fluid challenge. And if the patient is, remember, fluid challenge is a test. If the fluid challenge test is negative, please do not give further fluid. So some sort of prediction is required to give further fluid to this patient. And ideally, PLR can be a good thing for this. So I agree with the answer of 3. Go to the next scenario. A 42-year-old male, chronic liver disease, presented to us with abdominal distension. He was in shock with the arterial blood pressure of 100/52 with a grade 5 mottling. The whole body is mottled. Can you see from the photograph? And CRT was 8 seconds, lactate was 6 millimole per liter. He was intubated with lung protective ventilation. He already had received 1500 ml of plasma light, and he also received 100 ml of 20% albumin. Norepinephrine infusion was started at a dose of 10 microgram per minute. So what shall we do in this patient? What is the next best step? Shall we give 250 ml 5% albumin bolus? Shall we go for 500 ml of plasma light bolus if the end expiratory occlusion test shows fluid responsiveness? Shall we increase the norepinephrine dose to target the high MAP? Or shall we go for a dobutamine infusion, or shall we add vasopressin in this patient? So we have a patient of CLD with septic shock. Blood pressure is maintained with low dose of norepinephrine, has received lot of fluid, 1.5 liter of ringal lactate plus plasma light plus albumin, but continues to be hypoperfused. He is on ventilator with an SpO2 of 90%, with an FiO2 of 70% and PEEP of 12. Is very, very hypoxic. Now, what should be the best option for this patient? Your time starts now. So anyone in favor of fluid?
They're going
Confused?
for 5% albumin and norepinephrine.
Okay.
Albumin and norepinephrine.
Okay. Okay. So if you see, the biggest challenge for this patient is if you go for further fluid, there are two things which can happen. One, any fluid can actually increase the abdominal pressure. Okay. Second thing is this patient is already too hypoxic. SpO2 is maintained only with a 90% SpO2 is maintained only with a FiO2 of 70% with a PEEP of 12. So giving further fluid, a little bit of fluid can actually disbalance the whole thing. So let's do, so here comes the role of fluid tolerance. This is a clinical judgment based on some clinical findings and some investigation findings, whether, some technical issue. I think that is the only thing I can do. Just give me a minute. I'll just try to do it.
Hello, sir.
Rupsa, I think Sari is having.
Sir, okay, sir. Okay, sir. No issue.
Something is
Actually,
wrong
one
with
of our delegate is asking to make the PPT full screen.
because even I can't make the PPT full screen. There is something technical problem.
Sir, maybe you
Sir,
could
you can do one thing. You can
and you
stop
can
the
come.
screen share and then again reshare.
It's the screen has gone completely blank. I don't know why.
So I think you could maybe log out and again come back, sir. Maybe that should.
Sir, I
The
can
whole
help you.
screen
I
has
can
gone blank. Mhm.
sir, should I stop your screen share from my end?
But how does it going to help? Screen is shown.
And then, sir, after then you can again reshare.
So the screen has gone blank.
Okay, sir, I understood.
Just
Then,
a
sir,
minute. Just
you can.
a minute.
Yes, sir. Yes, sir. Take your time.
Yeah. Yeah. Now I can see it. Okay. I'll stop sharing, then again start sharing. Is it okay?
Yes, sir, definitely.
Okay. This is your screen? No, this is my screen. Okay, is it visible now?
Yes, sir, it is perfectly visible.
Well, I'm so sorry for the whole technical glitch. And so this is these are the options we had. And if you see, this is where here comes the role of fluid tolerance. So fluid tolerance, whether our patient will be more harmed by giving fluid or not. This can be assessed a bit from the clinical things, whether the worsening hypoxia is there, abdominal pressure is rising or not, or we can do something, some echocardiographic functions like LV function is we can assess. We can assess the LV filling pressure with echocardiography with E by E prime ratio. We can look for the beer profile in lung ultrasound, or we can look for extravascular lung water, and we can do some VAXS, the venous access ultrasound. Based on this, we have to make a clinical judgment whether our patient will be harmed by giving fluid or not. In our patient, he's a patient of CLD, chronic liver disease, and he's very hypoxic, and probably has got an abdominal compartment syndrome. Here, giving further fluid will probably be harmful. So we should not give fluid in such patients. So what options we have? Either we can increase the norepinephrine infusion, which is already in a very low dose, or we can combine norepinephrine with vasopressin. And what about, just to summarize on the arterial pressure, how much should be our mean arterial pressure target? So usually in the initial surviving sepsis guidelines says, okay, we start with a mean arterial pressure of 60 to 65 with a diastolic blood pressure of more than 50 millimeter of mercury. So this is our usual vasopressor target. But if our perfusion is not maintained with this target, as we can see in our patient, his MAP is more than 65, but perfusion is still not maintained, and we can't give fluid to this patient. So what shall we do? We can do something called a vasopressor challenge. So increase the vasopressor either by increasing the norepinephrine or adding a vasopressin, and maintain a MAP of 80 to 85 millimeter of mercury. Okay, wait for 30 minutes or for 1 hour. If you find with the revised target of 80 to 85 millimeter of mercury, if patient's perfusion improves, then you maintain the revised MAP target. If the perfusion does not increase with this revised MAP target of 80 to 85 millimeter of mercury, come back to the previous target of 60 to 65 millimeter of mercury and look for other options to improve the perfusion, like maybe give dobutamine or look for other things. So this strategy of vasopressor challenge was widely used in Andromeda shock trial published in JAMA in 2019. And we have been using it since 2019 onward. So this is a useful option to personalize the MAP target for our patient. So in this patient, of course, we will not give fluid. We can go for a vasopressor challenge just to see whether our patient improves with increased mean arterial pressure. Something is wrong. Okay, let's go for the next case, a 64-year-old female. We have time, Swarna Deepak? Hello?
Yes, sir. Another 5 minutes or 6
5
minutes.
minutes. Okay. So we quickly go through this. And uncontrolled diabetes with hypertension, again with pyelonephritis. And this time, blood pressure is fine. This patient, after DJ stenting and after this extremity is warm, CRT is less than 3 seconds, heart rate is tachycardic, but ABP is around 72 millimeter of mercury of MAP with a norepinephrine infusion. Lactate has come down from 6.8 to 4.8. he has started passing some urine, 50 ml in since admission. And she has already received some fluid and 100 ml of 20% albumin. So question is, what is the next best step for this resuscitating this patient? Shall we give further fluid to this patient? Shall we look for SCVO2 and start some dobutamine infusion? Shall we stop vasopressin infusion and stop resuscitation altogether? Which one? So our patient looks like a normalized CRT, lactate has gone down significantly. Shall we stop resuscitation and shall we continue with the resuscitation? So in the absence of things, we can see that this patient is already resuscitated. His MAP is maintained with some dose of norepinephrine. Her MAP, her CRT has gone down to less than 3 seconds. Her lactate, though elevated, but it has significantly reduced from the previous dose of 6.8 to 4.8. So there is no need of going for further resuscitation for this patient. Now, which one is better, CRT or lactate? I think the debate is now over. I think CRT targeted resuscitation is significantly better compared to a lactate targeted resuscitation, as has been shown in Andromeda shock study. And this is how we perform the CRT in our patients. We can discuss it later on. Now, when to stop? When the patient is no longer fluid responsive, patient is not fluid tolerant, patient's resuscitation target is achieved. There is something called hemodynamic coherence, which is lost. When further improvement in macro hemodynamics is not going to improve the micro hemodynamics, stop the resuscitation altogether. Or when the patient can be managed with oral or enteral feeding. In all those conditions, we have to, this is now right time to stop the fluid, and this should be the appropriate duration of the fluid. Final slide, 25-year-old female, vasculitic disorder. She underwent some surgery, and on postoperative day 7, she's oliguric with a urine output of 15 to 20 ml per hour for past 3 hours. She had a CRT of less than 3 seconds. Her lactates are elevated with 3.2 millimole per liter. This is day 7, and she has already had a cumulative fluid balance of more than 16,500 ml, 16.5 liters, hopping. Now here comes, I'll not go into the questions. So this is the type of patient. This patient is not in shock, though she's on some low dose of norepinephrine, but her CRT is maintained. She has got clear evidence of some abdominal compartment syndrome with a low urine output, and her positive balance is 16,500 ml. So we should not give further fluid to this patient. This is the right patient to start some albumin and furosemide infusion, as has been shown in this beautiful study by George Martin and Greg Martin and his colleagues from France, where they have shown in such patients giving an infusion of albumin plus furosemide achieves the magic things. And we should not forget the consequences of fluid overload, which increasing mortality and something like global increased permeability syndrome. So these patients require de-resuscitation or evacuation, and she is in this phase. So just to conclude, I think we need to use fluid more judiciously. We should treat it like a drug. We should understand in which stage of resuscitation our patient is and try to minimize the IV fluid as much as possible without causing harm to this patient. And I believe this strategy could be useful. At the salvage stage, use small bolus, start early vasopressor. In the optimization phase, always look for fluid responsiveness or do some fluid challenge, and give fluid only if the patient is fluid responsive or the fluid challenge is positive. Look for the fluid tolerance. If there is no fluid tolerance or fluid intolerance, do not give fluid. Hyperoncotic albumin, we need more data in this stage. Vasopressor should be started after 1.5 to 2 liters of fluid if it has already not been started. And we should go for a CRT guided resuscitation. In the stabilization phase, we should avoid maintenance fluid altogether because remember, it occupies 33% of the overall fluid volume. And if at all you want to use maintenance fluid, use moderately hypotonic fluid like 0.4% saline with dextrose. And remember there is something called fluid creep. Look for what fluid you are using for dilution and whether can you reduce the volume of fluid. For example, if you are giving polymyxin B in 500 ml of saline, try to minimize it to 250 ml of saline. If you are giving 500 ml of clarithromycin, maybe reduce to 250 ml of IV fluid. The clarithromycin is diluted usually in 500 ml. You can dilute it in 250 ml. If you are giving linezolid IV, which contains 300 ml per bottle, you can switch over to tablet if possible. So this is how also we can reduce our total cumulative fluid balance. And of course, we should not forget in certain patients, we need to go for a de-escalation or evacuation. And for that, a combination of 20 to 25% albumin plus diuretic or in sometimes ultrafiltration is useful. Thank you very much for your kind attention. I'll be happy to take any questions.
Thank you so much, sir. As usual, I think it's a wonderful lecture from you. Learned so many things. We have a couple of questions, sir. We may not take completely in view of the time shortage. One question asked by them was, is there a difference between various balanced solutions? What is your preferred choice between them? There are a lot of formulae.
Yes, we need to take care of many things. First of all, as we have discussed, all balance of solutions are not same. They are significantly different in terms of compositions, in terms of what is the buffering substance available, and in terms of something called SID. Now, first come to the SID. SID is the difference between the strong cations and the strong anions. Now, there is a simple formula. If the SID of a substance, of a fluid, is more than the bicarbonate of the patient, giving fluid of that particular fluid in a large volume will produce metabolic alkalosis. For example, we have a fluid called plasma light. Remember, I don't have any financial conflict of interest with any company. Plasma light or KB light has a SID of around 50. And our normal bicarbonate is around 24. So if you give 2 liters of plasma light to us or to our patients, there is a high chance that it will produce metabolic alkalosis. In contrast, if the SID of the fluid is less than 24, less than the bicarbonate of the patient, SID, it will produce metabolic acidosis. For example, normal saline, 0.9% saline, it has an SID of 0. It is simply sodium minus chloride, 154 minus 154, it is 0. So SID is significantly lower than the 24 magic number of bicarbonate. So giving saline will produce metabolic acidosis. 1. This may not be very, very significant for patients with septic shock, but this may be very, very significant for our patients of trauma, where the death threat, the coagulopathy, the and the hypothermia and acidosis that can produce increased mortality. So coagulopathy is one thing which can be a factor. Second factor is the buffering substance. Lactate is present in ringal lactate, whereas acetate is the main buffering substance in plasma light and steropundin. So lactate is almost exclusively metabolized in patients with liver failure. So in patients who has got a Child-Pugh class C, if you want to give a large volume of lactate, it may not be metabolized fast. So maybe I'll prefer acetate in such patients. Acetate is metabolized in every tissue of the body. Okay. Third thing is often the company people, they promote that, okay, certain compounds like ringal lactate and steropundin contains calcium. So whether calcium gets bound to when you give blood transfusion along with ringal lactate or steropundin, it can actually precipitate calcium citrate, but it doesn't happen. This is a myth. Fourth thing is potassium content of the balance salt solution. Actually, despite having potassium in balance salt solution, it does not produce hyperkalemia. Remember, most of the balance salt solution they produce metabolic alkalosis. So metabolic alkalosis can actually produce hypokalemia, not hyperkalemia. In contrast, normal saline large volume can produce hyperkalemia by virtue of metabolic acidosis. Finally, do not forget the osmolality of a substance. In patients with head injury, if you give hypoosmolar fluid, you will have a cerebral edema. So and when you go for the osmolality of a particular substance, remember there are two types of osmolality. One is the calculated osmolality based on the actual composition of the fluid. Another is something called actual osmolality, or when the osmolality is checked in body temperature. The actual osmolality of plasma light and ringer lactate is very low. Plasma light, it is around 270, whereas ringer lactate, it is around 257, which is both are hypoosmolar compared to our serum. So they both have a propensity to produce cerebral edema in patients with TBI or patients with high incidence of raised ICP. Comparatively, the saline has got a osmolality of 285 and tirofundine has got a osmolality of around 290. So both these drugs, both these IV fluids may be useful in patients with traumatic brain injury. So we can have another session on this issue, but this is as a brief. So probably, but of course, we should not forget the availability and the cost. Ringer lactate is very, very cheap. So in my practice, we use a lot of ringer lactate. We usually avoid saline, but in specific cases, we use plasma light or tirofundine, as I have discussed.
Thank you, sir. I think you answered the second questions also. Some of them are related to the specific one like TBI. So we'd be closing the session, sir. Thank you so much for taking your time.
Thank you so much.
So most of the students are very grateful. I think they learned so many things. So we'll be looking forward to hear from you in the next session, sir, in the disease-specific conditions. Thank you so much, sir. And we'd like to thank
so if any student has got any question or query, you can contact me in intensivist1972@gmail.com. INTEN. I'm sharing it in the chat box. You can contact me directly. Yes, over mail. Intensivist.
Sir, it will be better if you share it by your talk, sir, because they won't be able to see us the chat box.
You
can type it. This is the number. Okay.
Yes, sir. हम वो mail में डाल the contacts को mail के भेज देते sir.
So they can directly contact me. I'll try to answer whenever is possible.
Thank you so much, sir.
Thank you so much.
Thank you, Rup sir. Thank you, Clearly.
Thank you so much, sir. Thank you so much, everyone, for extending us.
Okay.
Thank you, sir. Thank you. Thank you for extending us the opportunity to host the session. So with all your permission, I would like to conclude here and good night. Thank you.
Thank you. Good night.